Okay, I think we'll get started. Before I introduce Dr. Nguyen, today we're going to be talking about updates in clinical trials in MS, relapsing, progressive symptomatic therapies, and stem cells. Good afternoon. I hope you all enjoyed this morning's session. My name is Nicole Sammartino, the Manager of Client Services at the National MS Society. Sorry, I got a script, guys. So I wanted to just make mention that I wanted to remind everyone, if you've not yet filled out your survey, please do so at the conclusion of this program today. It's my pleasure to introduce Dr. Nguyen, Dr. Daniel Nguyen. He is the Director of Clinical Research for Consultants in Neurology, as well as the Co-Director of the MS Center, which is designated by the National MS Society as a comprehensive center for MS care. Dr. Nguyen and his colleagues treat more than 3,000 patients with MS, assisted by Catherine Meyer, RN, Clinical Research Coordinator. The practice maintains a number of clinical trials to develop new treatments for MS. Dr. Nguyen is a popular speaker for the chapter and a member of the Healthcare Advisory Committee. Thank you, Dr. Nguyen.
So at the end of the Cubs game, I want to hear like at least at 10. At the end of my talk, my staff's going to hold up those W signs, you know. So thank you very much. It's a pleasure to be here and each year to announce advancements that really have been made in MS. I mean, just since last year alone, as some of you know, there are 3 additional disease-modifying therapies on the market for treating multiple sclerosis. And again, as I mentioned from the panel, the very first drug was shown to be effective even in primary progressive MS. That was announced at the European meeting just a couple of weeks ago. That drug we've also been using for several years in treating patients with relapsing forms of MS. They're going to apply it to the FDA to have it approved for all types of MS. Because how many people do we want to cure of MS? You got it. Very good. The quick group. The slow group's in the other room, I guess. So today I'm going to quickly run through a couple quick housekeeping things. The disease-modifying therapies, despite some of the questions of the panel, are not instead of taking care of yourself. Not instead of exercising. They're not instead of eating healthy. They're not instead of, spoiling the people in your life who love you, especially when you need them the most. And the work that has been done in our center, we've been involved in more than 80 multi-center trials for medications for MS. I've been involved in the trials of essentially all the medications on the market. Some perhaps yet to come soon, some which you'll never hear about because unfortunately not every trial obviously worked. This work cannot be done without the assistance of several people. You. We're always needing partners to assist us in doing this. I hate MS, not more than many of you, just longer than some of you. And I could go in my garage, try to tinker around. I can't cure MS by myself. As much as you hate MS, your garage may not be more clever than mine. Curing MS in your garage, if you can do it, please do it. I mean, after all, Steve Jobs did help create the Macintosh computer in a garage. But, in MS, we want people to assist with us. So people are interested in involving in MS, aspects of MS, whether or not it's a disease-modifying therapy drug for helping people walk, decreasing pain. There are studies like that. The individualized exercise programs, we have those as well. The other very, very important people I'd be in big trouble, but also remiss, so I didn't acknowledge, is really the staff that I'm blessed to work with. And if you would just stand, I'd like to introduce you, please. Kathy Meyer, who has been the director of clinical research with me at Consultants MS Center for just short of 18 years. Dr. Vasileva, a neurologist, who's also very active, involved in a research center, and Susan McMillan, a nurse practitioner, who, again, I know there are questions about stem cells. Prior to coming to our center as a nurse practitioner, she worked in the stem cell group at Northwestern in stem cells for cancer, and prior to that, in oncology at Rush, and then again had neuroscience nursing prior to that, working with us as well. So again, what I'm going to talk about today primarily are the medications for treating multiple sclerosis. And as I mentioned, this is not to diminish all the other important things that we all need to do to stay well. As Dr. Bernard said, if your MS is cured but you die of diabetes or hypertension, it's not going to do anybody very much good. A quick list of the approvals I think people know. 1993, the very first drug, beta-serin, was FDA approved for treating multiple sclerosis. There are now 13 drugs. They quickly came in a bunch. Again, last year or two, the Copaxone 40 milligrams 3 times a week was approved, showing equal efficacy to the 20 daily. Plegridy, the every other week version of low-dose, low-frequency interferon, and Lemtrada, really a breakthrough therapy, a therapy given once a year and literally not even every year. Lemtrada was the first drug that actually not only slowed down the progression of MS in every trial of it, but actually the average person who received that drug actually improved. So a very much out-of-the-box kind of result on that trial. As many of you know, there are now 8 injectables, 5 brands of interferon, Rebev, beta-serin, Xtavia, Avonex, and Plegridy, 2 gluteramine acetate medicines, Copaxone, Glatopa. Glatopa is a generic form of Copaxone, but it was never studied actually in humans or actually in mice. So if you have generic MS, generic family and friends, I recommend taking the generic one. It's actually more expensive than the brand 40 milligram 3 times a week version of Copaxone. 3 IV therapies. The first one, Novantrone, which is also generic now. Tasabri, one which is familiar to many of you, I'm sure. And again, the one that was simply approved last November in the United States. A year before that, outside the United States, Lemtrada, elotuzumab. And of course, several oral medications. The first, a little bit more than 5 years ago now, Gilenya, Fingolimod, Aubagio. Aubagio was approved a little more than 3 years ago for MS, but has been on the market since the 1990s for treating rheumatoid arthritis, sort of a reworked rheumatoid arthritis medication. Because rheumatoid is so much more common than MS, there's more experience actually in using that active chemical in people than there is any 3 MS drugs added together. And then Tecfidera is the most recently approved oral medication for treating MS. Again, there are other medications coming in the pipeline. Worldwide, there are 6 generic Copaxone-like molecules. The only one, as I mentioned, that was approved is that one in the middle from Sandoz Momenta, Glatopa. There are others as well, but none of these have been approved. We do not really know the status, whether or not they'll get approved in the U.S. The price has unfortunately not diminished. The price of the generic Copaxone is, the wholesale cost is over $63,000. There are numerous generic interferons outside the United States. We're waiting to see if the government will allow these to come to the United States as so-called biosimilar medications that have not yet been approved in the U.S. And then Novantrone, mitoxantrone, approved as a branded drug specifically for MS in 2000, became generic several years ago. A year's worth of that drug costs less than half a syringe of Plegridy, just to put it in perspective, about $400 a year. Again, that's a drug we give quarterly. It's approved for progressive MS, worsening forms of MS. But again, it's not used as much anymore, although it is a very easy drug to administer. There are many trials that have recently completed and some ongoing. One drug I like to always talk about is Liquidamode. It's an oral medication given once a day. The drug had a very surprising outcome in the trial. It had a relatively small effect on MRI scan. Most drugs we use for MS decrease inflammation. That's how they work. But the drug had a relatively modest effect on MRI scan. On relapses, a decreased relapses, better than certain of the injectable drugs, not as well as some of the other ones. But we took a look at how much it slowed disability. It was actually more than most of them on the market. So it was very dramatic. So that was very confusing to us. We were one of 6 sites in the world that did spectroscopy on the patients who were in the study. At our site, a large number of patients, and the drug seems to stimulate myelin regrowth and preventing permanent damage from episodes of inflammation, from attacks of MS. People more likely to get better should they have an episode. There's a third ongoing trial in relapsing MS, the Concerto trial, using yet a higher dose of that medication because the drug was almost without side effects. A few people had mild increase in liver enzymes. The only people who even had the most modest increase in liver enzymes that are studied turned out to be placebo patients. And now for the last several months, there's another trial going on, the Arpeggio trial, again with 2 doses of drug, 0.6 milligrams and 1 milligram in primary progressive MS. So again, very strong data behind this medication, a lot of safety, based upon a drug that was originally studied in MS more than 20 years ago. Lemtrada, the phase 2 trial was announced several years ago. I presented the phase the results of the phase 2 5-year data at the European meeting several years ago. We just presented the 5-year data from the phase 3 trial at ECTRIMS week before last. In the phase 2 trial, these trials were not against placebo, trial, but against what at that time was felt to be the most effective therapy for MS, Rebif, high-dose, high-frequency interferon. In that trial, Lemtrada decreased relapses more than Rebif than Tesabri did in that trial against placebo. So again, a kind of out-of-the-box effect, very, very powerful effect. Lemtrada elotuzumab was previously been used at some centers doing stem cell transplant, hematologic stem cells like at Northwestern, as a conditioning agent before giving stem cells. But instead of giving it with the stem cells and Cytoxan, this drug by itself, we just give it as an outpatient in the office or in one of the infusion centers. It's an easy medication to give, but requires ongoing following. Again, it was approved in the United States November 15th last year, more than a year before that outside of the United States. Outside of the United States, it does have an indication to be given people, even at the time, the onset of the disease. In the United States, it's when people perhaps fail 1 or 2 previous therapies. Daclizumab, high-yield process from combination Biogen, now AbbVie, Abbott. Previously Facet Biotech, previously PDL Biopharma. That's a drug given as a shot under the skin once a month. Again, we led the phase 2 trial, the earlier phase development of the medication. It did have a decrease in relapse rate in phase 3, as you can see, 45% compared against Avonex, so not as effective, not as high of a number, let's say, we've seen from, let's say, some of the oral medications in their head-to-head trials against Avonex. But again, that's not against placebo, but again, against an active comparator. Again, it was mentioned from the stage, we try to stop doing placebo-controlled trials when we have multiple drugs which we know work. We don't want to do a study against a placebo because we can do better than that now. My brother was one of the top people for the American Psychiatric Association for many years, and he would cull the cartoons from talks given to the national meeting, and he gave me this one. There's these people standing at the gravestone, look at the tombstone, and it says, he got the placebo. So we try to not do that anymore. Again, hematologic stem cell transplant, this present study at Northwestern, people have ongoing relapses within the first 5 years of MS. So not at any time, not in progressive MS, not later in the disease, but early in the disease, failing therapy. Liquidomode, again, a higher dose of liquidomode, like I mentioned a moment ago, and also the Arpeggio trial in people with primary progressive multiple sclerosis. We have a T-cell vaccine trial called Ability. Basically, we take individuals living with MS. You have certain blood cells that react abnormally against myelin. I have some that react abnormally against penicillin. I have a penicillin allergy. I have a very simple strategy for dealing with having penicillin allergy. Can you know what it is? I don't take penicillin, right, exactly. But you can't not have myelin. You've tried that, it doesn't work. So basically what we do in that trial is we take a sample of your blood, we look for myelin-reactive T cells, which essentially everyone with MS has. We then take a larger sample of blood, and then we isolate those myelin-reactive T cells from your blood, and we clone them in our laboratory. We treat them so they can't continue to divide and inject them back. The body recognizes them as foreign because we've treated them so they can't divide, and so the body will destroy them rapidly. But because they're clones of the ones in you, your immune system turns against the MS and helps destroy myelin-reactive T cells. In the trial in relapsing MS, the more we could reduce those cells, the more disease completely shut off. Now that's being studied in secondary progressive multiple sclerosis as well. If someone had an identical twin with MS, your drug would work in you, but not in them. It's that highly individualized. Mastibib is an oral therapy in secondary progressive MS. The study's largely being done, though, outside of the U.S. It works on mast cells or other kind of glial cell, which I can talk more about if you have interest. Rituximab, generic name for Rituxan, is a chimeric anti-CD20 monoclonal antibody. It binds to B cells, the cells that make antibodies, like antibodies against nerve or other things. It's approved for treating rheumatoid arthritis and certain other diseases. We now have a humanized version of rituximab. That's called ocrelizumab. Ocrelizumab, we presented the data again 2 weeks ago in forms of relapsing MS, the OPERA-1 and OPERA-2 trial, and then the Oratorio trial, the trial in primary progressive MS, the first trial that showed a dramatic effect at even slowing down people with primary progressive multiple sclerosis. The previous trial in primary progressive MS in Rituxan was negative. In those patients who had active lesions on their scan, contrast-enhancing lesions that had an effect, but overall it didn't. It was very interesting. In the ocrelizumab trial, it did have an effect in primary progressive, even though less than a fourth of patients in that study had active lesions. When I saw the initial demographics, like who got into the trial, and very few people had active disease in primary progressive MS, I thought the trial was not going to work. It did work. So again, that company, Roche, the largest manufacturer of drugs for cancer, is likely going to apply first quarter of this next year to have that drug approved. It's given twice here as an IV. There are a few medications we give as pre-medications, but again, it was very well tolerated. Ofatumumab is a fully humanized monoclonal antibody, again binds to CD20, decreases B cells. The drug is actually already on the market. It's not approved yet for MS, but for other conditions. The drug was owned by GlaxoSmithKline, GSK. Glaxo got rid of their oncology division, and they sold off the rights to this drug for MS for $1 billion to Novartis. So, some companies occasionally abandon research projects, but usually not after they invest $1 billion. So this is also very exciting. We did that trial for ocrelizumab. We usually give 125 milligrams of solumedrol, Tylenol, Benadryl beforehand, a few other medications, perhaps maybe a little anti-nausea medicine. Rituxan, people may be getting infused like all day. Ocrelizumab takes 4 hours to infuse. Ofatumumab is a shot under the skin. Tylenol, Benadryl, a shot, you go home. It's very simple. But again, very active drug. But the dose of ofatumumab was extraordinarily low, just 3 milligrams, a much, much lower dose, whereas rituximab, the original trial dose was 2,000 milligrams. Rituxan is chimeric antibody. Most of the molecule is mouse. Ocrelizumab is humanized. It's 10% mouse, 90% human, like Tysabri is 10% mouse, 90% human. Ofatumumab is fully human. It's not made from humans, but it's made in a human. The molecule has no animal bits in it, so to speak. There are follow-up drugs of drugs that are in the market. So the first oral therapy that came to market was Gilenya, as some of you know, but one of the side effects of that drug is slowing of the heart rate, very, very rare incidence of macular edema, which actually may or may not really be related to the drug. It's not clear yet. So one of the follow-up drugs is the drug from Receptos, our PC1063. The rights to that drug were just bought out by Celgene, another very large biotech company, for a very large amount of money. That drug worked like Gilenya in the earlier trial, but did not have the cardiac effects. Again, that trial is now ongoing, just finished enrolling patients. The second of those two trials, the 302 trial, was one of the fastest enrolling trials ever for multiple sclerosis, despite the fact there are more than a dozen medications already on the market for MS. Seraflimod, ONO-4641, also had a nice profile like Gilenya. Doesn't cause the heart rate issues, but the company that was developing the drug, Serono, for financial reasons, simply did not take it to the next phase of the study, tending to concentrate on other therapeutic areas. I love to tell you all the drug companies care about everybody with MS, but I think the people in those big offices in the corner, they concentrate on their stockholders first. NAV312 is a drug from Novartis. Again, less cardiac side effects. There was some stumbling in the trial. It's also being studied now with secondary progressive MS. Gilenya does cross the blood-brain barrier, so there's some reason why it may actually work in that as well. There was a study of Gilenya, I should also mention, in primary progressive MS, and there was a lot of excitement about that study when the trial was going on. We were not deciding the trial. The trial, unfortunately, did not work. There was no effect in Gilenya in primary progressive MS. Ponesimod is from Actelion. Again, that's a very similar drug to the other more selective S1P receptor modulators like Gilenya, but again, less cardiac side effects. This drug had a little bit more effect on the receptors that are in lung, and there's some shortness of breath and some ankle swelling on this medication. Again, this study is presently on hold. Now we have the drugs in the market. We want to see if we can do better. Gilenya, as I mentioned, the first drug FDA approved for MS, that's a pill. On the market now a little more than 5 years, more than 130,000 people have taken it, over 11,000 in a trial even. I mean, a massive clinical trial-based bit of data. The original dose studied was 5 milligrams. 5 milligrams versus 1.25 milligrams. If the 1.25 milligram wouldn't work, they did 5. The lower dose worked. The next phase study did 1.25 milligrams versus a half a milligram. And I don't think they thought the half milligram worked. It worked as well. It was safer in the higher dose. That's a dose that's presently on the market. When the FDA approved Gilenya, one of the requirements for approval was they do a study of yet a lower dose, and that's the ASSESS trial. This trial is actively enrolling patients. If people would like to be in this, please let us know. This is comparing the standard dose, a half milligram, versus a lower dose, a quarter of a milligram, and there's a lot of reason to think that will work. And the active comparator in that study is Copaxone. So again, no one's in a placebo arm. The trial does not have a placebo arm. If you want to be in a placebo, you have to be in a different study. That study is a dose-blinded study. In other words, you're on a pill or a shot. If you're on a pill, you won't know which 2 doses of Gilenya you're taking, a quarter of a milligram or half, but we can obviously always learn if we need to. If you're on Copaxone, you're on a shot, but not a pill, so one or the other. The receptors trial, which I mentioned a moment ago, on top, people were taking a pill daily and a shot once a week. That was a head-to-head trial against Avonex. But in that trial, everyone took a shot once a week, and everyone took a pill once a day. Oh, that fell over to remind me to tell you that we have flyers that talk about our different trials that people in the front have, and we're very, very happy to share them with you. Amantadine is a very old medication for treating multiple sclerosis. It was originally drugged, so who knows what amantadine was originally used for? Who knows? The flu, fighting the flu. And it was noted that people who got it had less fatigue who had MS. And there are a lot of other effects we see with this drug. The problem with it is a relatively short-acting medication, so the extended-release version of the medication that's been developed. And we're looking at the drug for the same indication that we use Ampyra for, to help people walk. Not only help people walk, to improve function of your arms, to help mood, and to help cognitive fatigue. So we're looking at cognitive function, mood, walking ability with this medication. Again, these drugs are, like that drug for treating a symptom of MS, it's not instead of your disease-modifying therapy. You can still, of course, be in disease-modifying therapy and be in a trial of one of the symptoms of MS. It's not instead of those. There's trials of Aubagio and Gilenya in children as well. Again, I took that poll a moment ago. You didn't know you answered this question already. Who do we want to cure for MS? Like everybody. MS is most commonly diagnosed between the ages, let's say, of 30 to 50, but 3% of individuals living with us will actually have their version before they're 10. So, like, no one wants to get MS, but no one wants their children to get MS, definitely. So there are 2 trials looking at these medications, Gilenya and Aubagio in children as well. The FDA and the government agencies give extra patent protection to encourage companies to also study the effect of these medications in children. Aubagio has been used, or let's say the precursor drug, leflutamide, Arava, has been used in treating juvenile rheumatoid arthritis, again for many years, so it's not without precedent studying this in developing adolescents. There's a trial of Tysabri in secondary progressive multiple sclerosis. Some people are excited about that. We included secondary progressive patients in the phase 2 trial of Tysabri before it got originally approved for relapsing MS. It didn't work in that phase, but we'll wait to see if it works in the much larger trial in secondary progressive MS. And then there's a trial of Cytoxan, the classic strongly immunosuppressive cell toxin, Cytoxan cell toxin, versus high-dose IV Solu-Medrol in multiple sclerosis. Several people came up to me this morning early, asked me about biotin. There have been some studies looking at biotin. Again, someone asked me that question when I was on the stage earlier about biotin. The dose of biotin is much higher than you can get in health food, so it's 10,000 times the dose. New England Compounding Pharmacy went out of business. People were, because some of the stuff was contaminated with fungus. There was another couple of compounding pharmacies that have been taken out of business. Many of the compounding pharmacies we used to get sterile medication from have been taken out of business as well by the government because with the compounding pharmacies, there's not the same regulation as with a regular drugstore. So I encourage people, if they're going to get biotin, to be part of the trial. There are 2 trials ongoing. The quality of the biotin is very well, regulated. If you just get it to yourself, like it sounds like a good idea, I read something in one of my MS newsletters about it, I would simply suggest conservatively you're experimenting on yourself. Anti-lingo, there is one ongoing trial in relapsing remitting MS. The results are not known yet. One trial in isolated optic neuritis. The conduction across the optic nerve was slightly faster in that study. That's what was announced. But there are several people who had to stop the trial because of safety concerns. So again, we're waiting to hear more information. This was discussed again at the European meeting a couple weeks ago, and then several months ago when the results of that trial were initially announced. But there's be a lot of interest in anti-lingo. This is a drug which the concept is to help repair myelin. Cannabis, that's a drug which everyone has self-experimented with for a long time. Someone asked about, on the podium, Dr. Modell, what about exercise-induced spasticity? That's like a really easy thing. You exercise and then you relax afterwards and you get rid of your spasticity with that. So one of the things, to be fair about this, many of the people who are working at the dispensaries, they really are advocates for people with MS. We want to support them. And there's a lot of interest in involving people in doing studies if people choose to be on cannabis to see how this affects your MS. If it makes you worse, we want to share that information. There's a saying in Russian, I'll say it in English. I can't speak Russian, so I better. A smart man learns from his mistakes, a wise person from others. So the more we can share the information, from design trials of using this, obviously the more people we can help with this medication. Certain symptoms of MS helps. Dr. Bernard mentioned that the use of cannabis may affect cognitive function. Most of the data for that actually is in children. Cannabis is not going to be available for medical use in children, at least not yet. Maybe in epilepsy, but not in other conditions. The abatacept trial was a failure. Lipoic acid, you can take lipoic acid orally. It's not absorbed. It has to be injected. There's a trial of it in secondary progressive MS. Ibutylast, there's a National Institute of Health sponsored trial. Northwestern is our local site for that. It's in primary progressive and secondary progressive MS. The previous trial with ibutylast did not work. There is a second trial that is ongoing now. I don't know how that will turn out. Innate Therapeutics has several very interesting types of approaches at looking at the genetic aspects of MS and trying to sort of re-engineer the abnormal immune response in MS, and has several drugs that are in very early stage development in looking at autoimmune diseases, including multiple sclerosis. Stem cell therapies. The origin of stem cell therapies partly comes from in people who have bad lymphoma, leukemia. They may receive stem cell transplants. They don't die of lymphoma or leukemia. Years ago, a person who had passed away after receiving a stem cell transplant, her brain was analyzed. And we found cells in her brain that had Y chromosomes because the donor for a stem cell transplant had been a man. And so we know that stem cells can turn into neural tissue. The question is not, does that happen? Will enough of them turn into neural tissue that cause a functional improvement? Because dying with MS, but you have Y chromosomes in your head will not necessarily be beneficial to you. The question is, can we make the stem cells grow enough that, again, we can cause sufficient return of function? Again, the neuroprotective agents. One study that was just announced again just recently, doxycycline, which is a generic form of tetracycline, been on the market for a long time. It blocks cells crossing the blood-brain barrier. There was a study in Canada, a randomized double-blind placebo-controlled trial of doxycycline at the time of first clinically malignant event, at the time of first episode of MS. People had to be given drug within 6 days of onset. And again, it decreased conversion to relapsing remitting MS by over 40%. Again, extremely inexpensive antibiotic. There will likely be future trials with that antibiotic in combination with some of the standard FDA-approved medications for MS. Again, diet. There's some studies suggesting a lower salt diet will help. The American Heart Association recommends less than a 2-gram diet. Most Americans have a 3 or 4 gram sodium diet. The highest salt diet in the world is in Asia, where actually MS is not as common. As I mentioned, if you do the cannabis route, just watch out for the taco chips. Coenzyme Q, there's several forms of that. Coenzyme Q, of course, you can get at vitamin stores. Some people are looking at that in different formulations of coenzyme Q, where it's very high levels of coenzyme Q in treating different forms of progressive multiple sclerosis, in the same way that's being looked at in certain other neurological diseases, such as Parkinson's disease. Again, as I mentioned 23 years ago, before 1993, there were no drugs FDA approved for MS. Now there's a baker's dozen, that's 13. I'm a big fan of baked goods. And now we have multiple injectables, orals, and IV therapies. The main advantage of orals is that they're pills, but they have some extra safety concerns. The advantage of some of the intravenously given drugs, they're very infrequently administered, but they again have some safety concerns about them. I like to say the treatment of MS is like building a house. The foundation of the house is the relationship with the healthcare provider. You want to have a relationship with someone you trust, you can talk to. Some symptoms of MS are not, you don't like them, but not embarrassing. Like you can't say it of your eye. Optimize, you have to tell someone that you can't say it of your eye. That's not really embarrassing. But if you have problems with your bladder, bowel, or sexual function or cognition, that might be embarrassing. So really have a relationship, with someone you can trust, talk to, and get in touch with quickly. I mean, the reason why our center is designed with so many staff, multiple MS nurses and multiple physicians, is really to make ourselves accessible. So the foundation is that level of trust you have with a person. Question was, I'm getting worse, but my MRI is the same. We don't treat MRIs at our center, we treat people who have MS. MRI is a tool we use in assessing MS, but we don't simply treat MRI scan. I'd rather have you spend 45 minutes with me than just 45 minutes in the tube getting a scan every few months. It's a much more useful way to help you do best. Again, as I mentioned, there are 2 generic or / biosimilar drugs, Novantrone, and then Glatopa, the generic Copaxone-like medication that the FDA allowed to be on the market just a little bit more than 2 months ago. When Glatopa got approved, I got nervous because I realized that about 15% of things in the National Enquirer is not true. A few things on the internet or in some of these presidential debates might require a little bit of fact-checking. But I don't know about you, but when I get a letter from the insurance company, I'm nervous before I open my letter, and I assume it's accurate. We're starting to realize the insurance companies do not realize that Tom Cruise and Ted Cruz are not twins. These are different people. We have seen multiple letters from insurance companies telling people they have to switch to the generic drug. What it really means is you have to have your doctor write a letter. We have been very successful getting people the medication they need, but it is more often than not going to require a per authorization. Again, people have sent me the letters. I saw the letters coming from insurance companies as long as 2.5 years ago before any generic drug was even approved. I got mailing just recently again from CVS Caremark saying that people had to switch. It's not true. It just requires a letter from your health provider, which is why, again, that foundation of curing MS is having a relationship that's strong with someone you trust who knows is on your side. The roof of the house, again, is the accoutrements we bring in, treatments for spasticity, pain, fatigue, a physical therapist, an occupational therapist, psychologist, your primary care doctor, bladder specialist, whatever else you need to bring in. And in terms of the wall of the house is disease-modifying therapy. And there's the house of straw, the house of sticks, and the house of bricks. You guessed I'm a brick fan, but not radioactive bricks. So you want to build that strong house together, foundation, the walls. The walls, the disease-modifying therapies, they used to say they decrease MRI lesions, relapses, and slow disability, but what are they really? These drugs are our defense against all of our worst nightmares. There are literally more than 200 trials going on right now. So people say, well, there's not a study for me. You looked in the wrong place. Ask people who are actively involved in these trials, what's available for me? I hear every now and then people coming to our center, and I say, well, I see me too, you see me, it's my previous doctor said this is my new normal. If I had a tooth abscess and needed a tooth pulled, and my dentist said, that's your new normal, I would do the same thing you would do. I would find a different dentist. And I don't have a lot of hair, but the woman who cuts my hair, if she just talked to the woman next to me and continued to cut my ear, I would get my hair changed, and the woman who cuts my hair is not in my health care plan, or the people closer to my house. Be as picky about a doctor as you are about the person who cuts your hair, at least. But some people just go, well, my insurance company says I have to go this one. This one's 5 minutes closer to my house. You can always find someone stupider closer to you. But find someone you're going to have a good relationship with. Don't we all know someone who has a bad haircut? Let's be honest, okay? So talk to other people people in your support groups or whatever, who really spends the time talking to you, who really spends the time answering your question. One woman did criticize me in the office the other day. She said, Dr. Wynn, one of the things I like about you is you never rush me, you never hurry me, you always give me all the time I need, and you spend all the time with me. But the thing I don't like about you, you do that for everyone who came in before me, too. So, again, we're here to create a world without MS. Start disease-modifying therapies early. The National MS Society recommended 20 years ago now that people, once they're diagnosed with MS, or more recently, have their first symptom consistent with MS, and are felt to be at high risk for MS, meaning have as few as 2 consistent characteristic lesions on MRI scan, go on therapy. And to stay on therapy, unless that therapy is clearly not working or a person has side effects which are problematic. For the Obama healthcare plan, we also have the commercials for the Luck healthcare plan. The person with the wrapping paper around the leg and the bubble wrap around their neck. Who needs healthcare plans? Who needs hospitals? Who's medicines? I have luck. What does MS have to do with luck? Bad luck. Okay, so don't pick the Luck healthcare plan. It's not particularly effective. So there are effective therapies. If you took one, it didn't work, or it made you sick, talk to your doctor, find one that's not going to make you sick. There's no reason to take one that could make you badly sick, or that did make you sick and keep on taking it. Aggressively pursue symptomatic therapy. Again, as Dr. Moto emphasized, some of the best therapies are not medications. I don't know of anybody's healthcare plan that says you can't exercise. I just haven't seen that in an insurance thing ever, okay? We encourage that. And I always, the simple rule I tell people is start with half of what you can do at most. If you always start with no more than half of what you know you can do, you'll always go, that was ridiculous. I know I can do a little bit more, and every time you'll do a little bit more. If you start exercising for an hour, you'll lie on the ground clutching your chest and said, that doctor had some good ideas, but that was not one of them. I'm never doing that again. So start where you are. And one of the things we're doing at our center, and others are as well, we're working with Dr. Mortal. I'm the physician in this project. We've had large funding for the last 9 years from the MS Society, is to help create that toolkit, help people create a customized exercise program for you. You get the person who you want to cut your hair. You get the person you want to take care of your mess. You can help with your doctor choose the disease-modifying therapy, but you also want to customize your exercise program to what you need, what would work in your life, the other responsibilities you have, but also your level of physical ability. Some people say, well, I can't exercise because I have too much fatigue or I have a bladder problem. We can treat your bladder, we can treat your fatigue as well. If that enables you to exercise more, that's not a bad thing. Insist on expert care and time. The government is moving to enforce consultation over the internet. If you want to buy marijuana over the internet, you can do that in California. You can't even do that in Illinois. Don't only get treatment for MS help over the internet. Now, that's a bad source of information, but don't have that be your primary source. Again, one of the nice things about is obviously there's no good place to have MS, but in Chicago, this is one of the richest cities in the country for being a lot of experts. There are many comprehensive care centers in Chicago. Northwestern was the first one in Illinois. Ours was the second. Now there are a few others as well. There are many people who've made it their life's work. I mean, Dr. Arneson, who was honored as a guest speaker last year, who won the Distal Award from the National MS Society, who spoke last year, I mean, he was the one who originally described stem cells in 1960. We have a lot of years of experience from many specialists. Dr. Stefosky, he's been working at MS Center Rush since he had hair. I mean, there are a lot of very, very smart people in Chicago who really, like myself, are committed to having MS go away. And when it goes away, I will fish for 2 weeks. It's the first day of trout season today, but we haven't cured it yet. I'll go fish for 2 weeks, and I'll sell clothing in the mall behind where my office is and actually make a decent living. But again, that's one of the reasons why we want the Cubs to win the World Series. Again, the answer to tomorrow's questions comes from the work we do together today. You can stay at home and just wait, pick up the newspaper every day. Did they cure MS yet? Did they cure MS yet? I have this collection of the cures of MS and the cause of MS that people have collected over the years from papers, from major newspapers, New York Times, Washington Post, LA Times, and a couple tossed in from the National Enquirer. Going back to the early 1960s, we still haven't found the cause or cure yet. But we will not do this as doctors alone. Someone living with MS by yourself, you may not do it either. But working together, we really can make this the end of MS. Really. We'll still have free dinners for you, don't worry about it. The gift of your time, talent, and treasury and humor can make this together. So again, we can make MS stand for mystery solved. In the same way that scientists turned America, the most feared disease by far in 1950, I remind everybody, was what? What was the most feared disease in 1950? By a mile. Polio. Polio was much worse than MS. It crippled a huge percent of the adult population. It killed babies. Extraordinarily contagious. The vaccine study started in 1953. There hasn't been one case of polio in the industrialized world for more than 50 years now. Last year, there were 248 cases in the entire world, all in a small part of Pakistan, neighboring India, where aid workers aren't allowed in. We're very close to ending polio thanks to the Bill and Melinda Gates Foundation, which, by the way, we work with as well. So again, make this dream we dream together come true. Let's work together. We want to get in the muck with you. And let's have that muck fest at the end of MS, and again, have MS stand for Mr. Solved. Thank you very much, and I'm happy to take questions. We have a question back there. So the question is, for someone diagnosed with clinical isolated syndrome, is treatment recommended? The answer is yes. The National MS Society for many years has recommended that from the time of first symptom, if a person has an MRI scan consistent with MS, meaning as few as 2 lesions, the person go on therapy. Plus, our definition of clinical isolated syndrome changed. So let me take a step back, because not everyone knows what that word means. So multiple sclerosis, 20 years ago we defined multiple sclerosis as more than one episode of neurologic symptoms lasting more than a day, consistent with MS, like typical for MS. And so if there was multiple sclerosis, you had to have more than one episode in the past. There was once a time people had one episode. We used to call that singular sclerosis. I like that term. It was easy for me to understand. But now we allow a second attack to be a change in MRI scan. And so we changed the term from singular sclerosis to clinically isolated syndrome. Now, if people have an enhancing lesion, even one on the scan, on their initial MRI scan, that is not in the area which is giving them that symptom. So just as an example, if someone had optic neuritis, an enhancing lesion anywhere in the central nervous system, brain, spinal cord, other than the optic nerve, that is relapsing remitting MS by the 2010 criteria. So it's really evolved what we call that. And those new criteria are more sensitive, but they have not decreased the specificity of the diagnosis. But it still will always take a clinician to work with you, is this MS? Because again, there could be other causes of optic neuritis or transverse myelitis, which your doctor wants to always exclude by certain perhaps blood tests and examining you. But yes, treatment is recommended. And some of the trials that are ongoing include people with clinically isolated syndrome. Oh, by the way, I can give short answers. Just ask me to and remind me. Thank you.
Oh, I don't really want that. Okay.
I was curious to know, your last slide mentioned there were 13 approved disease-modifying therapies. But your first slide, when you had the numbers of 83 and 3, that to me, I don't know, maybe my math is off, but that total of 14.
So I'm sorry, there are 7 injectables. There's 5 interferons, Rebif, Betaserin, Extavia, Avidex, and Plegridy. two glutaminylates, Copaxone, the FDA-approved studied one, and Glatopa. So those 5 injectables, 3 IV, Novantrone, Tysabri, Lemtrada, and then 3 oral medications, 2 capsules, Gilenya and Tecfidera, and 1 pill, Aubagio. No, I appreciate that.
This European trade agreement, that possibly lower the cost of medications, or is it
So the question, will this Pan-American Asian trade agreement lower cost of medications? It'll almost certainly do the opposite. There are a few major beneficiaries of the trade agreement. Basically, one of the aspects of the trade agreement is to protect patent protection, again, for software companies, for medications, for pharmaceutical companies. It may, though, even if passed, it actually may backfire and drop the cost of medications, because already India is starting to not honor patents for European American companies for medications. They call it patent law 2.0, and now Brazil is pulling out of it as well. And that India is not honoring the patents for rituximab, for example, commonly used cancer drug, Avastin, another very expensive cancer drug. They're not as worried about that, but they don't want, like Senator Grassley from Iowa suddenly going in the U.S. Senate, wow, we don't need to do that either. And there are actually strong arguments that people make against allowing patents for medicines, because research advances quickly. Why do you have to have so many years of protection? Because by the time you'd have the patent, we'd have a new drug. But if you're one who is spending your life's work trying to develop the drug, you might not like that idea. So there is a lot of controversy in that. Someone towards the back. In the orange, please.
Okay, I just wanted just a short explanation again of the I missed what it was.
So laquinimod is an oral medication, and exactly how any drug works, we don't know for sure, because we don't know what causes MS. What the drug seems to do is stimulate myelin regrowth. It did not decrease MRI lesions as strong as many of the drugs in the market. It did not decrease relapses as well as some of the drugs we have in the market. It worked better than some, but not as well as others. But it had one of the most dramatic effects of slowing progression of physical disability. It's a pill people take once a day. The third trial is presently ongoing in relapsing-remitting MS, Concerto, 0.6 milligrams versus, I think, 1.2 milligrams. Again, that's an active comparator trial again. And in addition, there's the Arpeggio trial looking at 2 different doses in primary progressive MS. In the primary progressive trials, we're looking at brain shrinkage or atrophy as one of the primary outcomes in that trial as well. In purple.
What trials are you doing for relapsing remitting neurons?
So there are numerous trials for relapsing-remitting MS in our office, and I'd love to spend the rest of the evening just listing them all off, but what I encourage you to do is to ask our research staff, all of you, and please be involved. We're happy to include anyone who'd like to participate. Not only drugs to slow down the disease, but drugs to treat symptoms of the disease. I'll give you, like people often say, well, you just do studies for young people. I'll name one study that we did years ago which led to an approval of a medication you've all heard of for MS indication, Botox for bladder. When we did that, the Dignity trial, and I talked about that at this meeting years ago, at like a breakout session, we included in the Dignity trial individuals up to age 90, even who were wheelchair bound all the time, like couldn't transfer even, from either MS or spinal cord injury, and that did get approved. It is a dramatically effective treatment for neurogenic bladder in MS, we thought originally we would have to dose people with the Botox for their bladder every 3 months. It's averaging about once every 10 months. So it's been really, a game changer for a lot of people. In all my years, you can tell I'm old, I've only learned 2 things, though, so far about women. Women like to smell pretty, which you all do, by the way, and be dry. So helping people's bladder is a good thing.
Going back to the quinine, you're talking about several studies, clinical studies with quinine, different doses and stuff. The problem is none of the doses or anything for quinine has been approved.
So, right, laquinimod is a drug that's still presently in trial. We have positive effects from 2 trials so far, and 2 ongoing trials yet. The FDA requires at least 2 trials to get a drug approved per indication. So a 3rd trial is being done in relapsing MS to satisfy both the American, the FDA, and the European regulatory agency, the EMA, but also to get indication in primary progressive MS because, again, this dramatic response we saw in spectroscopy. But some of the medications on the slide, the ones that I say are not approved, Like you can get Gilenya a 0.5 milligram, you can't buy a 1/4 milligram pill. So technically speaking, a 1/4 milligram dose of Gilenya is experimental. New for medicine means new and approved. New, not yet approved, is just called experimental. All the drugs we presently have on the market, we had when they were investigated.
Let me give you the microphone so everyone can hear. I'll hold it. Go ahead.
Oh, thank you. So it sounds like no matter if you have a little bit of MS, one little lesion or more, you should be on a disease-modifying medication. Did I hear that right?
So the most important thing to have, if you have MS or might have MS, is you have a doctor.
Yes.
And together, the 2 of you choose. If she or he thinks this is like the benefit and the risk match, then you have a match. Does that mean everyone with MS needs to be on a medication? No, it does not. But I would tell you the MS is an inflammatory disease of the brain and spinal cord. So it's like, think of it as a little fire. Not all lesions lead to an obvious disability at that time. But as time goes on, that might change.
Quick follow-up to that. So if you have a genetic mutation to hemochromatosis, can you have that treatment for that problem at the same time as taking a disease modification drug for MS?
Yes, you can. So that condition, if untreated, could lead to severe liver problems. One man I took care of years ago was in liver failure from hemochromatosis. He had severe high blood pressure, as well as having an autoimmune disease of his kidney, minimal change disease, and was on dialysis. But the illness that bothered him the most was his MS. And he wanted to be on Novantrum, the chemotherapy medication I talked about earlier for MS. And I said, I really can't give you this medication, David. I mean, your liver is bad and you're in kidney failure. So he really did not like my answer. So he talked to his nephrologist. She called me and said, don't worry about his kidneys. He's on dialysis. You can't make his kidneys worse. Even if they're removed, they're not doing anything. He's on dialysis. And the GI doctor called me and said, we'll watch his liver with you. And, we'll just see if he does okay. If we need anything, we'll change things. And actually, he got the drug and did extremely well and had no problem with his liver. And actually, only after we gave him 6 doses of medication, we had the strong improvement where we could stop the drug. Then I noticed you could actually dose it lower for a liver, and we even didn't do that for them. So what it really takes is someone who's experienced in treating someone with both conditions. People often complain to me, how come I have to take so many drugs? I used to be easier if you had one illness. And what's the easiest way not to have multiple illnesses? Like, I don't get money if people exercise. But it makes my job easier if you don't have diabetes, heart disease, bad arthritis, etc. So that's why we encourage people to do these things early. If you don't exercise when you're in your 20s, you're not going to probably notice it in your 20s. But when you get to be OLD, I don't have MS, but I have OLD, it's harder. A lot of people die of OLD. Don't laugh about it, please. We don't have support groups for OLD, although we do have community centers. Sure. So we were the second largest site for Lemtrada going back to the phase 2 trials. We did both phase 3 trials, the extension studies, and then the upcoming Topaz study. We have dozens of people on it. We have many people whose disease reversed markedly. When people go into clinical trials at our site, I tease them, I joke, please don't make it a package insert. I've enrolled almost as many people in clinical trials as anyone in North America over the years, having been involved in so many trials and because I'm really passionate about making this thing go away. I have some people who made package inserts. I have people in a lot of the different package inserts. although the University of Chicago had the person in the package insert for rebiff. The package insert for rebiff, it lists death. That was a patient in the University of Chicago in the evidence trial who was in an airplane crash, so it actually had nothing to do with the drug. But seriously, a lot of people who did have bad side effects in Lemtrada were actually our patients, but the difference is people have a low platelet count or a kidney issue. We had the one person with that. It's very easy to treat. The drug is given once a year, first year 5 days in a row, second year 3 days in a row. We have some people who have gone 9 years without treatment now, whose exam has become normal. In the trial, we followed an MRI scan at the 2-year time point. The people on rebiff, this was not a placebo-controlled trial, it was against rebiff. The people on rebiff, the amount of brain covered by lesions actually decreased by 6.5%. It decreased by 9.5% on Lemtrada. None of the other drugs actually decreased total lesion area. So this is really, the company's motto, Genzyme Sanofi, is to provide transformative therapies. So I heard that's like something out of the 60s, Go to some weekend event, you get transformed. So what do they mean by that? It's like something like never happened before. To have a drug you give once a year and not every year that can make people better. The average person actually had less disability than on the trial. And the vast majority of people, even after 5 years, have only had 2 doses of medicine. So it really is like something we haven't had before. What someone said to me several years ago about the drug, in some ways it's the very first non-chronically administered drug for any chronic illness. Like rheumatoid arthritis, epilepsy, high cholesterol, you take drugs forever. This, we have people who got 2 cycles of drug and nothing. I mean, really nothing. The woman who, the very first woman I put in the trial, actually we just saw her in follow-up the other day, and in the very first trial, the phase 2, people couldn't have been on a previous therapy. It's not that way now. And so I didn't know if this drug would work. It was going into an early phase trial. So I put someone in the trial I didn't think would respond to anything. Her mother's Puerto Rican, her father's African American. She had 42 contrast-enhancing lesions on her baseline scan. So extraordinarily active disease, a pattern people sometimes have referred to as malignant MS. It's been 11 years now, 12 years now. 11 years. She's had just a couple, up until recently, just had a couple of doses of drug. Her neurologic examination has become almost normal. She had no new MRI lesions until November last year when she had one new 2 millimeter lesion 7 years after being dosed. And a couple of years after her second dose of drug, she asked me if she could have another baby. I said, it's fine with me, but you have to ask your husband first. Of people we've had on that drug, there are several children born. The drug is out of the body in less than a month. The package insert says a woman can get pregnant 4 months after dosing. So, like, one group of people that we might target are women who want to have a family or enlarge their family. Because, if you're on Tisabri and you want to get pregnant, we want you to stop the drug. But the problem with stopping Tisabri, there's often a sudden resurgent disease activity. That doesn't happen with this. And so this is a drug good for younger people, but it's also older individuals as well. So, we just have time for 1 or 2 more
We
questions.
have time for one more question.
In the very far back.
I'll bring you the mic.
And by the way, I'm not going to run out, so please come up to us afterwards. And Kathy,
Okay,
and Elia, Susan.
Thank you
we're
very
happy to answer
much.
questions.
I have a question about the source of demyelinization versus remyelinization and as it relates to mercury and dental issues.
So what is the question?
Where does research stand in the United States and globally dealing with mercury as a source for the demyelinization and hopefully the possibility of remyelinization?
So mercury, as in amalgam fillings, is a different kind of mercury that causes loss of myelin. So the original research that was done was in Minamata Bay, Japan, where there's accidental industrial spilling into the bay, which caused a large population of people to get mercury poisoning. Even small amounts of mercury are very toxic to peripheral nerves like your arms or legs. To get enough to affect the brain, it's going to make most people just blind. So it doesn't cause relapse or remitting disease at all. There's no evidence that amalgam filling, mercury amalgam fillings, causes MS or makes MS worse. And in fact, the American Dental Association, American Bar Association have removed licenses from dentists who have told people that. But again, it's one of those things in our culture that exists, and it probably will never go away. But that's what the facts seem to suggest. So again, thank you very, very much for coming.
Thank you, Dr. Nguyen.
I also applaud Emma Sider making this available every year. And don't forget to fill out your evaluations. And if you need help writing my evaluation, I'll be happy to help you.
The next presentation will